Welcome back to the show. Today we are discussing maternity-related health care, maternal health and child health. And with me in studio is Fadosa Abdi, who is the Manager Programs and Schemes at NHIF, and Dr. Fraser Karua, who is the General Manager for AMREF Enterprises. And before the break, we were talking about Linda Mama, what Linda Mama is, how does one get registered, and where the services are offered, and that's both in public and private facilities and faith-based organizations. Now we want to look at financing of health, and before we start this second part of the discussion, let's listen in to Dr. Andrew Mulwa, who's the chair of the County Executive Committee Members for Health in the country, on his views on reimbursements by the national government and NHIF to cater for deliveries under the free maternity services and Linda Mama, that free maternity services that transitioned to Linda Mama. Let's take a listen.
Up to July 2017, the national government has been reimbursing county governments the compensations for the cost of deliveries that have taken place in our hospitals and other facilities. For health centers and dispensaries, each delivery we have been getting a reimbursement of 2,500 per delivery, and in hospitals 5,000 shillings every delivery.
I'll start with you, Dr. Fraser Karua. You know, we talk about the Abuja Declaration of 2001, where 15% of the health budget, of the national budget, should go into health. Now we are talking about reimbursing for services. We are reimbursing 2,500 for dispensaries and 5,000 Kenya shillings for hospital deliveries, and these are for deliveries only. Is this money adequate to offer quality healthcare services for these mothers?
So I think in isolation, when you look at the amounts, then you would be tempted to say that this is not enough, especially when you're thinking about a mother who will come and, have a complication, and knowing that delivery is sometimes complicated either by, obstructed labor or hypertension or bleeding. And so is this money enough to offer services to the women who present in the facilities? It depends on how they present to the facility. But I think it's to look at how do we ensure that the Linda Mama is part of a bigger pool within NHIF. As Fardosa was mentioning, if it moves to insurance, then you have a bigger pool of risk that allows you to spend more than just what is reimbursed, because that is what has been defined as a reimbursement rate for different levels of facilities. And I think as we look at health financing, we need to look at also what other ways can we finance healthcare without necessarily having to depend so much on the public health expenditure, which definitely needs to increase. But looking at the private sector, public-private partnerships becoming a key area of expansion in healthcare, where we actually can pool resources, that the domestic resources within our country, to ensure that mothers can access services and these services can be paid for. So I think we need to explore other models.
Yeah, I want you to hold on to that thought about public-private partnerships and other ways of offering healthcare services, because I want Fardosa to just comment on these reimbursements. Is it adequate to actually offer the services to these mothers?
If you look at the figures, the way Fraser said, it depends on how the facility is reinvesting back the money. We're talking about numbers. We're talking about mothers who are delivering under Linda Mama. We also have mothers who are expectant women who are also delivering using the national NHIF card. So there's so much money that is going to the counties through NHIF. We're also paying them for outpatient from our expanded benefit package. So it all draws back to, are they able to reinvest back that money, improve on their services based on that? So it might be enough for them to do most of the processes and to really build on what they need to invest in so that they can offer quality services.
One of the comments that the counties had was that NHIF is only reimbursing for delivery. They're not, that NHIF is not looking at pre-delivery, that's the antenatal clinics and the visits, which, well, is a better part of the pregnancy, and postnatal, where now you have mother and baby, that only this reimbursement is catering for the actual delivery. Is this the case?
Yeah, that's the case, Mercy. As I said earlier, when Linda Mama was transitioning, which was free maternity, it had to be done in phases. We had to first expand the network, bring in the private and the faith-based, and they were also just being reimbursed for delivery. Then the next stage was to bring in the public facilities, which happened from July last year. Now we are in the last stage where we've opened it up, we've expanded the benefit. We're now expanding it to postnatal and antenatal. So now it will be an expanded benefit package for mothers. So from what he mentioned, it's true. Currently, it's just deliveries. But we are finalizing on it. I'm sure by end of this month, we'll have rolled out antenatal and postnatal.
So, Dr. Fraser, who caters for the antenatal costs and the postnatal costs?
I think, one, it could be the county that takes the brunt of the costs that are incurred and mothers cannot pay. Because you have counties talking about how they actually must offset the bills of the mothers who are held in hospitals because they couldn't pay for their services. That's one way to look at it. Secondly, there's out-of-pocket expenditure, which is quite high, where the mother has to go back and dig from her pocket to pay for the services that she requires. And this is what we need to move away from if we're going to achieve universal health coverage. We need to reduce out-of-pocket expenditure and create schemes that allow households, mothers and their children to access health care without having to become impoverished or having catastrophic costs because they could not afford the services.
Okay. And earlier you'd mentioned about looking at other ways of financing this health. Which are these other ways that, well, that at the end of the day will still be sustainable for the counties and the country without the counties and the country being dependent on some external players?
I think when you look at the models for health financing, one that we haven't really explored to its full potential is public-private partnerships. Because while the public sector has largely been held accountable for providing financing for healthcare, there are players within the country, this is a private sector, that can actually finance some of these services. And this doesn't mean just providing the financial aspects, but creating the infrastructure, bringing in innovation that could allow for women to have better quality of services. And so I think if we look at health financing holistically, then it means we have different models that we can explore. I think we also need to look at other ways of collecting and pulling money from the public sector, be it tax, be it the sin tax, as it's called, from the cigarettes or from alcohol or even from the airlines. I think we need to explore all these mechanisms because we know that the donor funding is actually, reducing. And so how do we as a country look at the various ways of financing that could benefit the citizens of this country? And I think one of the areas that's coming up is, the social impact investments, including social impact bonds, where you actually are using financial instruments to finance healthcare in some markets. And I think we need to explore those as ways to actually increase the pool of funds that are accessible for the women and the children in this country.
Okay, thank you. Fadosa, is NHIF and the government, by extension, looking at other ways of financing Linda Mama to make it sustainable, other than looking at the small pool of, the bigger public cake?
Yeah. Currently, because Linda Mama is fully funded by the government, what we are trying to look at is how to transition these mothers to join NHIF and have an insurance cover. Now, there's the two categories. We have those who can pay. So we have to segregate the ones who can pay from their pockets and pay for an insurance cover. And then we have the other segment that can't really pay. And that's where we're also trying to reach out to the counties to be able for them to finance some of these vulnerable groups that are identified within the county so as to have them transition to an insurance cover. Yeah.
Okay, so you're looking at the counties to pay,
That
but
is
the
one way.
counties still get the funding from, it's actually from the bigger national government funds
Yes.
that the counties get their portion. So it's still the same pool, isn't it?
Yes, and that's one way. We also have private-public partnerships, as Fraser had mentioned. There was something we're also doing with AMREF in Liaison. We're also doing something with Farm Access. We're trying to come up with models whereby we can also help to finance some of these vulnerable groups.
Okay.
Yeah.
Okay, we'll take another short break from that, and when we come back from the break, we'll be answering some of your questions and concerns that you've raised concerning Linda Mama and this topic about covering healthcare for women and children. So stay with us.